we're moving on to chapter 2. So these are women's health issues, preventative care, birth control, and the nurse's role with women's health. Here in the PowerPoint, there are 2 links here. Go ahead and click on them, watch the video, look around the CDC website, and we can talk about your thoughts. Okay, so goals of healthy people 2030, right? Where are we trying to go? Where are we progressing towards? So for women's health, we want women over 40 to have more mammograms so that we can prevent breast cancer. We want women over 21 to have pap smears so we can prevent cervical cancer. We want to reduce hip fractures. We want to reduce osteoporosis. We want to reduce STIs and pelvic inflammatory disease. So preventative care for women, breast care. So we want to look for right tumors. We want to prevent cancer in the breast, in the vaginal area. We want a pelvic examination. So for the breast care, women can do it themselves. So they should do it monthly, or they can see we want them to see their primary care provider yearly as well. Mammograms, of course, that can be scheduled with their primary. Vulvar exams, you're looking for lesions, you're looking for masses, and you just, lightly palpate. You can use a mirror with your hand to look. And then pap smears. So pap smears start at 21, every 3 years for women between 21 and 29, 5 years for between 30 and 65, and then no screening is necessary after 65. I don't personally agree with these numbers, but that, it's our healthcare system. If we're really preventing cervical cancer, it used to be when I was in my 20s, it was every 6 months to a year. I don't know why it's changed, especially when you were sexually active and you're young and you do all the screenings, because they do all the testing every 6 months. You would do the testing and the pap smears. I don't know why it's changed. And then for the for your breast care. So if you want to look on page 26, this is the teaching that you would give to your patients on how to perform a breast exam on themselves. Laying down, standing up, in the shower, right? You want to move in circular motions, palpating with the tips of your fingers, starting at the nipple and working your way out. Menstrual disorders, again. So if women, some things are normal, some things aren't. So as nurses, we know what's normal, what to look for, what not to look for, what is not necessary. So we do the teaching, we provide support, we find support for our patients. So amenorrhea, the absence of menstruation. So obviously before you get your period, pregnancy, after menopause, you're not going to have a period. That's amenorrhea. Primary amenorrhea, that's if you fail to go through puberty before 16, if you don't have secondary sex characteristics, if you don't have your period by age 16. Now, again, this can be okay. There are some women who don't get their period till they're 18, and that's fine. That's normal. That's just how they are. But sometimes there is an issue. So that's why we want screening. You got to go to your primary just to rule other things out. And then, of course, secondary is if you've already had your period and then you stop getting your period. Obviously, you want to do some testing to make sure that, there's nothing wrong. Abnormal bleeding, so too frequent, too long in duration, and excessive amount. So too frequent if you're getting your period every other week, too long duration if your period lasts 2 to 3 weeks, and excessive amount of bleeding if your period only lasts a couple days, but it's excessive and you're soaking pads and tampons every hour or two. So excessive being greater than 80 milliliters a month. And then, so obviously we want to figure out what's going on. So it could be from pregnancy complications, lesions on the vagina, cervix, or uterus, breakthrough bleeding on contraceptives. Birth control is not 100%. endocrine disorders, so on and so forth. Okay, so next slide. All right, Mittelschmerz is pain that many women experience around ovulation near the middle of their menstrual cycle. Sorry, I wanted to go back to this. So I just wanted to give you a couple definitions. Menorrhagia is the intermenstrual bleeding, usually normal in amount, but occurs at irregular intervals. Menorrhagia refers to menstrual bleeding that is excessive in amount. The average female loses about 35 milliliters of blood during normal menstruation. So blood loss greater than 80 milliliters, like I was talking about. So I just wanted to, okay. Mittelschmerz, middle pain, discomfort reporting around ovulation. Just take some ibuprofen and usually, or Tylenol or whatever. It's usually just a little discomfort or annoying and harmless. Dysmenorrhea refers to painful menses or cramps. It can start on the onset of menses with a spasmodic cramping. Lower abdomen and lower back, nausea, vomiting, diarrhea. Those are also common, especially for women who have not been pregnant. And so if there's no evidence of pelvic abnormality, then it should be okay. So it is discomfort, and it can again be relieved through usually they'd say like Motrin, Advil, like naproxen, ibuprofen. Those usually help. Heat, of course. So endometriosis. So endometriosis is when the endometrium, the lining of the uterus, which is usually inside the uterus, starts to be created outside of the uterus. So this can be painful. You can cause the inflammation cascade, and so it can also cause painful intercourse. It can cause infertility, and sometimes they might have to do a hysterectomy or do a laser ablation to help alleviate that. So, premenstrual dysphoric disorder, PMDD. So, yeah, so it was formerly called the premenstrual syndrome, associated with abnormal serotonin response to normal changes in estrogen levels. Symptoms occur between ovulation and the onset of menstruation. So those last 2 weeks of the cycle, and are not present the week after menstruation has occurred. So the last 2 weeks. So 14 days is ovulation. So those 2 weeks, so between ovulate or whatever, a 1 week, sorry, between ovulation and menstruation. So should be relieved after that. So diagnosis and symptoms: depression, anxiety, increased sensitivity to rejection, irritability, decreased interest in usual activities, difficulty in concentrating, lethargy, change in appetite, change in sleep habits, feeling overwhelmed, physical symptoms like breast tenderness, bloating, weight gain, headaches. Stress management, that's what we do, right? Stress management when we're depressed. Limiting sugar, caffeine, and salty foods can actually help. And a lot of times, oral contraceptives can help relieve a lot of that. Sometimes they prescribe birth control, oral contraceptive birth control, to help regulate periods, to help with anemia. So a lot of times that last week of the pills will just be iron. And also it does help with mood. So they do prescribe that not just as birth control, but sometimes because their hormones, the PO, that's what they're based off of. So they help regulate your hormones. And so they help with the depression and anxiety and all these other things that happen during our cycle. Um, so, vaginal flora. Again, so when I was talking about that balance, so here are some things that can disrupt that balance, that normal, healthy vagina. So again, antibiotics because of the yeast. So you can get yeast infections, douching because it changes the pH. Sexual intercourse, again, changes the pH. And then diabetes, because as we know that bacteria is drawn to sugar. So it can promote bacterial growth. So when preventing vaginal infections, wear cotton underwear, avoid tight nylon and spandex, wipe front to back, frequent hand washing, high fiber, low fat diets, exercising, and avoiding those hygiene products. TSS, toxic shock syndrome. I haven't seen anything lately. It's probably still going on though. When I was growing up, that was like the big thing. So the tampons, if they're left in too long. So when I was growing up, they always said change them every 6 hours. I think now they recommend 4 just to be on the safe side, because when they're if the tampon is in there for 8 hours or more, then obviously it attracts bacteria. It's just not healthy. So all the toxins and the bacteria, it's this Staphylococcus aureus. It right, so it can cause other things. Okay, so the Staphylococcus aureus and other toxins. So it produces toxins that can cause shock or coagulation issues and tissue damage. So toxic shock syndrome is associated with the trapping of bacteria within the reproductive tract for a long period of time. So things that can increase that: the high absorbency tampons for prolonged periods of time, the use of a diaphragm or cervical cap for contraception, especially after childbirth. So the signs and symptoms: the spiking fever, flu-like symptoms, hypotension, right? That shock, generalized rash like a sunburn, and skin peeling from the palms and hands and soles of the feet, um, fainting, low blood pressure, the hypotension. Um, so teaching, very important to prevent this. We're teaching, right? Change your tampon every 4 hours and look for signs and symptoms. Hand hygiene. Do not use super absorbent tampons. You can use pads instead, especially when you're sleeping. Don't use a tampon when you sleep. Don't use the diaphragm, a cervical cap, especially during menstrual periods. So, okay, so as a nurse, again, educating, vaginal health, right? Protecting that balance in there. So again, when they put women on antibiotics, a lot of times they'll offer like an antifungal to go with it to help prevent that yeast infection. Prevention of STIs, right? And then high risk behaviors, right? We're always educating people on safe sex practices, reduction of sex partners, and non-judgmentally. So family planning. So So I'm just noticing, I don't see a slide on pelvic inflammatory disease. So just for the FYI, so on page 34, you can read about this. Pelvic inflammatory disease is an infection of the upper reproductive tract. It can be asymptomatic and if untreated, and caused by untreated STIs. The cervix, the uterine cavity, fallopian tubes, and pelvic cavity are usually involved in the infection. It can result in infertility. So sometimes symptoms, so again, that fever, pelvic pain, abnormal vaginal discharge, nausea, anorexia, and irregular vaginal bleeding. So of course you go to your provider, they will do an abdomen and a pelvic exam and that's, when they palpate, it's going to be tender. Blood tests, you're going to look at your leukocytes, their elevated sed rate. They can do cultures in the cervical canal. And so the most common are gonorrhea and chlamydia. So, okay. So back to the nurse's role. So again, prevention, right? STDs, STIs, whatever they call them now. So when we talk to couples or women about contraception, right? So family planning, which is there's that saying that women choose babies, which is I have 5 and I only planned for 1 out of the 5. So a lot of times these things are not planned, but getting people to start planning, and thinking about this, taking your multivitamin and, not drinking and smoking and, all these other things if you're looking to get pregnant or if you're worried about being pregnant. Also, so there are various contraceptive methods, right? So we've got the natural methods, we have birth control, condoms. So the natural, so you talk to what people want. So, and of course it's, their choice, depending on their age, their health, their culture, how many sex partners they have, so on and so forth. So there's a lot that goes into what type of contraceptive is right for that woman, right? So, are they going to be responsible and take a pill every day at the same time, right? That kind of thing. Or are they against hormone, do they want to do something more natural? So these are sort of the things that you talk about. So there's the temporary contraceptive, which so they are like the pill. Sorry, there wasn't a slide for the actual family planning one, but so basal body temperature, that is when you take your temperature at the same time throughout the day during your cycle. So your temperature will vary during ovulation. So it usually rises slightly, about 0.4 degrees Fahrenheit when you're ovulating. So that's something that some women do, is taking their temperature all the time. Then there's something you can test your mucus. And so depending on the consistency of your mucus, women can know if they're ovulating. And then, of course, tracking your cycle. So that's really important. And I really think that even if you're not doing it for birth control purposes, I think it's good to encourage girls to track their period. It's just a good habit to get into, and then they will know, right? So they'll get to know when their period is coming, how long, if something changes, right? So it's always good just to get them in that habit. And so, and that way they know, is it a 28-day cycle, a 32-day cycle, right? Is it irregular? Is it regular? So it's just a good habit to get into. Of course, then there's abstinence. So the temporary ones, we're going to talk about hormonal contraceptives. So, well, this is, yeah, so the pill, let's see. So combined birth controls, which work with, they use estrogen, and some use estrogen and progesterone or estrogen and progesterone pills. There's the patch, the ring, the depot shot, IUDs, copper IUDs, and next one on, that's the implant. So again, we want to look at the habits and what they can do if they want all those hormones, if they don't, if they want, the IUD in there, or if they don't, if they're scared of it or they don't trust it or they just don't want it, right? So it's just what they can or can't do. But then also remember, there are a lot of pregnancies with women who take oral pills because there's other medications that will decrease its effectiveness. So, antibiotics like ampicillin, tricycline, these are big ones that, you know, women don't often think about. And the funny thing is that doctors don't normally ask. So, a lot of women get pregnant because, they had an infection and they were taking antibiotics. They had strep throat and they were taking antibiotics. They had pneumonia, they were taking antibiotics, and they weren't told that their oral pill would not be effective and to use other means while they were on birth control. So a lot of pregnancies happen that way. So just remember, it's all about the um, education. So always tell, if you're on a pill, if you're on birth control and the doctor orders your medication, tell them you're on, you're not, whatever your pregnancy status is or not, or, etc. Okay, so the barrier types. So these are your condoms, your cervical caps, your sponges. There's a female condom, your spermicides. Um, and these can be effective. Of course, we know they're not 100%. There's also planning involved with some of them. Obviously, you have to buy the condoms, but also taking the time to put them on. Some of them, like the diaphragm, you have to put on a couple hours before menstruation. And then, so on page 39, there's a how to use a diaphragm. So you can look at that for teaching purposes. Um, and then, of course, on page 41, how to put on a male condom. There's also the female condom. So what's this now? So how well does your birth control work, right? So this is the big thing. It's not 100%. Of course, some are better than others. Naturally, withdrawal or pulling out, coitus interruptus, doesn't always work because some sperm will be ejaculated before the male orgasm. So that's not 100%. Douching, that's not 100% either. Might just give you an infection, but still cause pregnancy. And then, of course, breastfeeding. So we know that breastfeeding, and there is research that says that it does slow ovulation and it does help prevent pregnancy. But again, it's not 100%. And in fact, I don't even think it's really research to the point where they can say it's, reliable enough to do. And then we have the morning after pill. Again, take as soon as, the unprotected sex, you want to take it. The longer you wait, the less effective it is. And some of them there's one, and some of them there's two. And then again, remember your ethics, right? Because if we're dealing with children, if she's 14, 15, 16, she's still a child. So just, always ask your, wherever you work, and state, because states are different too. So just keep that in mind. And I don't mean that they can't take it. I'm talking about like their, what their home life is, and are they going to be okay taking it, and, really educating them. So male sterilization, vasectomies, now they say they're reversible. And I think the sooner you reverse them, the more effective that is. But I think the longer you wait, that you just can't do that anymore. So female sterilization, tubals, and hysterectomies. Total hysterectomy is probably with a bilateral oophorectomy. That's when they take out the ovaries too. That's probably the safest. But it has been said that couples have gotten pregnant when one's had a vasectomy and the other's had a tubal. So it's careful. And then of course there's menopause. So the cessation of your menstrual period after a year has gone by because of the decreased hormones. Um, so of course it can be life changing in terms of, again, your women's bodies are changing again. So it's just another stage of um, life. But you still can get pregnant, especially during that period where you're not really through it yet, because there is that sort of gray area of going through it. Um, and then, of course, again, we want to look at cultural awareness stuff, and that's why we educate and we talk to our patients and, what are their perceptions of what's going on. And then there is hormone replacement therapy to help prevent sort of the side effects, like hot flashes and stuff like that. And electrolyte replacement, prevention of osteoporosis. That's one of the ones. Um, again, educating, right? Um, and taking medications as prescribed. So thinking a lot about that, thinking about your patient population and how much they can remember. Okay.